now we're going to speak about primary health care and the minor global health. Good morning, everybody. Two people are lecturing today. This is me, Paul Mertens, speaking about primary health care, and Pieter van den Hombergh, he's going to speak about family medicine. So for students, it might be of interest to know what I am doing. I am a consultant in infectious disease control, health policy and management, and international health and tropical medicine. And I have several positions. I am still connected to the public health department of Erasmus MC, and also in Kenya visiting professor and advisor to the government of one of the counties in Kenya. And I run non-governmental organizations, the Dutch Kenyan Health Foundation. So for people in Dutch, I'm artsmaatschappij en gezondheid in different fields. Imagine you are the medical director of the World Health Organization and being asked to design a healthcare system for the world. What would your healthcare system look like? So what I'm going to explain you is, in summary, why the idea of primary healthcare came in the last part of the last century, based on challenges in healthcare and different patterns and determinants of health, and healthcare models will be discussed, and then in specific primary healthcare. And I'm going to give you an example of primary healthcare. So what is primary healthcare? Just to give you a broad definition, this is a role of society approach to health and well-being, centered on the needs and preferences of individuals, families, and communities. And it addresses the broader determinants of health and focuses on the comprehensive and interrelated aspects of physical, mental, and social health and well-being. That is what the WHO tells you about primary health care. But why came primary health care? The 17th of last century, and a very important person, John Rawls, he wrote a book about justice. And it was a reflection on how to achieve a just and righteous society. That was the era of those days. And he develops a principle of justice through the use of an artificial device, what he called the original position, in which everybody decides principles of justice from behind a veil of ignorance. So what does that mean? The veil of ignorance means that no one knows his place in his future society, his class position or social status, nor does anyone know his fortune in the distribution of natural assets and abilities, his intelligence, strengths, and the like. So you don't know who you are going to be in the future society you're going to design yourself. And Rawls assumes that the parties do not know their conception of the good and their special psychological propensities. So this field essentially blinds people to all facts about themselves, so they can not tailor principles to their own advantage. According to Rawls, ignorance of these details about oneself will lead to principles that are fair to all. So he will not privilege himself, and so that is a kind of thinking exercise. And then what were the results of this? That each person is to have an equal right to the most extensive total system of equal basic liberties compatible with a similar system of liberty for all. And social and economic inequalities are to be arranged so that they are both to the greatest benefit of the least advantage, consistent with the just saving principle, and attached to the offices and positions open to all under conditions of fair equality and opportunity. So this is how this society should be shaped. according to Roberts, if you use the veal as a method. So what else was going on? We got more insight in the development and more insight in determinants of health. So how do diseases arise? That was something people start thinking about. So can somebody give an answer on this question? I don't hear anything. So let me tell you, diseases do not arise through gods or devils, neither in a vacuum, might be in the United States. But diseases arise through interaction between the host, agent, and environment. And that is what we call the triad of diseases. So there is a kind of interaction between the host, agent, and environment. And characteristics of the host, agent, and environment can be considered as determinants, risk factors of diseases, and as potential targets to control diseases. So when you look more in detail, human beings, the host, have personal and interpersonal situations. Agents are biological, chemical, physical, or nutrition-wise, and the environment is geographical, climate, social, environmental, health situation, preventive and curative healthcare systems. And you can elaborate on that. You can think about intelligence level, for example. There's a clear-cut relationship between health and intelligence. How more intelligent you are, how better you're schooled, how more you know, how longer you live in good health. If your family background is forbidding vaccines, you will not get vaccination, and so on. So agents are biological, chemical, alcohol, tobacco use. That is a very important agent. Radiation, fire, mechanical, road traffic accidents, and then the quality and the availability and the abundance of nutrition in a society, of course. And then where do you live? Do you live in a malaria area due to geographical and climate situation? In what type of social system you live? Do you have human rights? How is the healthcare system in the society? Is there any prevention? And what is the environmental health situation? You think about indoor and outdoor pollution and things like that. So in 1974, the Ministry of Health of Canada, Mr. Lalonde, asked his people, his civil servants, how do I have to spend the money I have to improve the healthcare in Canada? And they gave him this system. The health of a population is dependent on things like lifestyle, the healthcare system, the physical surrounding, and also some biological factors. In 1980, we got the Black Report in England. It was an expert committee guided by Mr. Black, and he found that although overall health had improved in England since the introduction of the welfare state, there was a widespread health inequality, and the main cause was economic inequality. So the death rate for men in social class low 5 was twice that for men in social class 1, and the gap between the two was increasing, not reducing, as was expected. So in 1990-81, we got a very impressive slide in which was shown that there is a relationship between the gross national product per inhabitant and the life expectancy in different birth cohorts in the world. So you could in 1900 see that there was a relationship, higher the gross national product per person, per inhabitant, how higher the life expectancy. And that impresses the people very much. So we got a new idea about health and how to deal with it. So it was not only from a biological perspective, but you should have to look to the whole society to find out what determinants have influence on the health of the people. So my conclusion is determinants of health have many dimensions. So now again, you become again the director of the WHO. What would your healthcare system look like with this knowledge? So I want to expand on this, challenges in healthcare, mortality and morbidity in the world. So there is not one healthcare system you can design. If you look to the burden of disease and death in the world, we use two ways to look to it. We look to the mortality, so years of life lost, the ELL, and to the morbidity through the years lived with disability, the ELD, the ILD. So together it makes DALYs, disability adjusted life years lost in a society. You know about this, but so healthcare challenges in the world. So let us look to patterns of morbidity and mortality. What are the leading causes of death? It is still around the same. We have especially cardiovascular disease, infectious diseases. So of the 60 million people who die, most of them die of cardiovascular diseases and infectious diseases. So if you look more specific to infectious diseases, you find lower respiratory infections, HIV, tuberculosis, and so on. And that causes 25% of all mortality in the world. So if you look more specific to these infectious diseases causing so much death, you find, looking to the different infectious diseases like pertussis, tuberculosis, measles, malaria, diarrheal disease, HIV, and lower respiratory infections, that something can be done about it. You can vaccinate against pertussis, tuberculosis, measles, and so on. So vaccination could be something very important. That lower respiratory infections is something you can also interrupt very easily. If you look to HIV, there are very different patterns in the world when you look to the prevalence of HIV, especially in Africa with very high prevalences. And if you look to the deaths due to AIDS, it is very different patterns in the world with high and low prevalence areas. Malaria, the same. Malaria is around the equator with different countries having different malaria prevalences. Tuberculosis, the same, still the most important infectious disease with 9 million new cases a year and 2 million people dying. And the incidences, the new cases per 100,000 people is very different in the world. You see Mongolia and Russia and Africa have higher incidences. So why? Tuberculosis and HIV combined. HIV lowers the immunity capacity of human beings. So in the areas where you have a lot of TB, the combination is sometimes very prevalent, but very different in different countries. When we look to COVID-19 deaths, we have very different patterns. These are registered numbers, but the policy of Mr. Trump makes that the United States have higher mortality rates per 1 million people than the Netherlands, for example, although they don't differ a lot. Healthcare challenges in the world, patterns of causes, places, times, and sex, and age are different for morbidity and mortality. So if you look to the distribution of mortality in high and low income countries, for example, you see that non-communicable diseases are very important in those rich countries and respiratory infections not at all, compared to middle-income countries where you see more infectious diseases and injuries and perinatal conditions. And if you look to the distribution of this in lower economic countries in Africa and Southeast Asia, you see that infectious diseases become very important, and non-communicable diseases are important as well. But so what you see, the distribution of this in different countries with different socio-economic situations are different. Mortality due to different diseases in the world over time. So there is a changing pattern when you look to diarrhea, for example, in the world. It is decreasing, lower respiratory infections as well, due to all kinds of interventions. But what you also see is that cardiovascular diseases are increasing over time. And you see that HIV is coming and that some diseases disappear and others come up. Mortality and morbidity due to different diseases in 1990 and 2010, low and high income regions. So in high income regions, you see more cancer, and in low income regions, you see more diarrhea and so different patterns and DALIs in different countries. So mortality and morbidity of different diseases in the world by sex and age. So when you look to DALIs and age, you see that when you're young, you have a different disease pattern compared to when you're old. And morbidity due to different diseases in high and low income countries. Also, but now looking to years of life lost with disabilities. So how are people ill in the different countries? In high income countries, you have different patterns compared to low income countries. You see in low income countries, of course, you have nutritional deficiency more than in rich countries. That is what you can understand, of course. And then morbidity in relation to sex and age. So as a child, you get different diseases compared to when you're old. So my conclusion is, in the world, healthcare challenges differ due to different patterns in morbidity and mortality and causes, places, time, sex, and age. So now with this knowledge, you again become the director of World Health Organization. What should you do? More specific risk factors underlying morbidity and mortality in the world. So let us look into this. Here you see the 19 leading risk factors by country and income level. So the blue ones are high income levels and the brown ones are low income levels. And you see that high blood pressure causes different amounts of people dying compared to low income countries. And when you look to iron deficiency, that is something in middle income countries and low income countries, but you don't find it, of course, in high income countries. Fruit and vegetable intake, you see, and it is more in middle income, and the rich, they don't eat a lot of fruits anymore. So these are the 19 leading risks by country income, resulting in 60 million deaths. And then again, you see different patterns in different countries with different income levels. So the under 5-year mortality due to specific diseases and malnutrition. So when you look to the reasons of under 5 mortality, you see that there are all kinds of reasons like prematurity, pneumonia, injuries, but behind it you see a different pattern which adds to the risk factor through undernutrition to each cause of death. So in low-income countries, you have more undernutrition, and that adds to the contribution of under 5 mortality rates. Abortion and maternal problems because of lack of contraceptives in the in the Netherlands, women have a very nice position, but in many countries, not at all. They have even lack of contraception. So it results in Africa in many unsafe abortions and also maternal conditions. It is sometimes shocking. A country like Kenya, the maternal mortality rates are, for example, 500 per 100,000 women compared to 2 per 100,000 in the Netherlands. That's due to tobacco use. You see that in many countries there is still a lot of smoking going on, but in some countries people smoke more than in other countries, and that results in different patterns in, for example, lung carcinoma. So we have also different environmental risk factors. When you ever went to big cities with a lot of environmental pollution, that is different in the world in different countries. Lead exposure, indoor smoke from solid fuels, and so on and so on. Disease burden attributable to 24 health risk factors in different income regions. So something can be done. Some risk factors are really attributing to disease burden, so we could prevent these things as well, of course. And then we have to transition over time of risk factors. So the traditional risk factors are coming down, like undernutrition, indoor air pollution, water sanitation, and hygiene. That is all improving, but tobacco use is still increasing, and physical inactivity and things like that. So over time, you have different risk factors. So my conclusion in part 3 is differences in health between countries' populations are caused by different patterns of determinants, and there is so a need for a broad spectrum of health care. So let me show you this famous statement of the Lancet. There is no necessary biological reason why life expectancy should be 48 years longer in Japan than in Sierra Leone, or 20 years shorter in Australian Aboriginal and Torres Strait Island people than in other Australians. So what can be gained? So if you look to, there is life expectancy can be gained if you decrease the determinants of health, increase in life expectancy due to absence of selected risk factors, especially in Africa. You can increase the life expectancy tremendously, but also still in high income countries. So again, with this knowledge, what should you do now? My suggestion is adapt healthcare system to differences in patterns and determinants of health. But how do you do that? So let me go to the Netherlands. The Netherlands has a very rational way of organizing the healthcare system. We know a lot of determinants of health in the Netherlands, and we make every 4 years a booklet, and in which we tell what should be done. So we use this type of models of determinants about physical surrounding, lifestyle, social surrounding, and all other types of, we look to different determinants, and then we look what kind of healthcare system should we need in the Netherlands. So we have a rational healthcare system based on knowledge about determinants of health. We have primary prevention, like vaccination programs. We have secondary prevention, like screening on breast cancer and other diseases. We have a very good curative healthcare system. We spend half of our healthcare money in healthcare, and because we have many elderly people who need a lot of care. So that is the way we built our healthcare system in the Netherlands. So now to primary healthcare, 1978. So we had more and more insight in what the reasons of health were in the world. We had Mr. Rowells, we have all types of thinking. So we made a big conference in Alma Ata. And health is a human right was declared. Think about Rowells. Health for all, justice for all, and health for all by the year 2000. So, and that was based on unacceptable levels of health disparities, need for social and economic development, and the right of people to participate in planning and implementation of healthcare. So the Alma Ata conference gave 5 key elements to achieve this: universal coverage reforms, service delivery reforms, public policy reforms, and leadership reforms based on different elements, like integration of health into all sectors. So that requires a public health policy reform. So primary healthcare became a core concept of the WHO goal to tackle politically, socially, and economically unacceptable health inequalities in all countries. So it resulted in a primary healthcare movement of professionals, institutions, government, civil society organizations, researcher, grassroots organizations. So primary healthcare refers to essential health, and it is based on scientifically sound and social acceptable methods and technology. It is universal healthcare, healthcare accessible and financially affordable to all individuals and families in a community or in a country. It is through their full participation at a cost that the community and the country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. So this approach beyond traditional healthcare systems, and it focuses really on health equity, producing social policy. So it includes all areas that play a role in health, such as access to health services, environmental health care, and lifestyle knowledge and practice. It is essential care, social acceptable, based on evidence, universal available, and services are prevention, promotion, cure, rehabilitation, environmental health, and lifestyle services. So targeting the key determinants of health, that is what primary healthcare does: health education, water supply, sanitation, nutrition. It promotes self-reliance of communities and particular attention for common causes of morbidity and mortality, essential drugs, infectious disease control like with immunizations and family planning. And it is linked to other levels of healthcare through referral systems. So this is a scheme which tells you about public health. And so you have medicine, midwifery, nursing, social work, and other health professionals. And this idea, you have a kind of case manager and the family health nurse. We have that at this moment in the Netherlands as well. We have teams who go to families to look into their health and then they refer to other caregivers. And one of them is very important, the family physician, and Dr. van der Hombergh is going to speak about that. But also health centers, hospital service specialists, nurses, and special doctor, and you refer to them in this primary healthcare system. So there are 4 basic principles of primary healthcare. Equitable distribution of health, looking to gender, color, urban, rural, social class. Community participation, use of local, national, other available resources considered as sustainable due to its grassroots nature and emphasis on self-sufficiency. You have to think about very poor areas. Let me give you an example of my own work in Africa. Here we see a community gathering money for a dispensary. There is no health care at all, so they should like to have a dispensary. So they come together in what we call Harambee meetings. They give money, and together people are building their dispensary with the means they have on their level. And here you see the result. A dispensary is still working. It was built by the community, and here they were building a maternity and toilets and things like that. And they organized themselves through a health village committee. With a lady chairman, unbelievable. But that is what primary health care is. So community participation is healthcare force development, trained physician, nurse, allied health professions. So the health workforce needs to be developed, and community health workers are very important in poverty-stricken areas. I'm going to show you that to give you an example. Use of appropriate medical technology is very important. Technology should be accessible, affordable, feasible, and cultural accepted. No refrigerators, vaccine, cold storage is very important, but heart lung machines, is it important when you don't have more than $40 per person per year to build your healthcare system? So even that type of discussions we have in the Netherlands as well. And that is about total body scans and things like that. And then the multi-sectoral approach. Health cannot be improved by intervention in formal health sectors only. You have also to think about food, agriculture, education and health education, and communication about prevailing health problems, methods of preventing, controlling. When you look now to COVID-19, what is the government in the Netherlands doing? They're doing this. So multi-sectoral approach, other sectors equally important in promoting health are housing, public works, safe water, basic sanitation, rural development, industry, jobs, community organization, local governments, and voluntary organizations. So primary health care recognizes that health is not a short-lived intervention, but an ongoing process improving people's lives and advocating political interventions and rather than passive acceptance of economic conditions. Of course, there was criticism. It was no clear targets, too broad, not attainable because of the cost and aid needed. But then they improved the system and then we got GOBI as well. So very specific programs were implemented, like gross monitoring of children, oral rehydration, fights for breastfeeding and immunization. So primary health care should be targeted on the main problems in an area and should also have specific and measurable outcomes. So beside gross mode and immunization, family planning was introduced, female education, and food supplementation. Now I'm going to take you to one example, because it might be something very abstract, but let me take you to just the minor global health and what students can learn in the situation that they went with me to Kenya. This is a group of students in 2017. And you see they are sitting in front of the dispensary I showed you. You see the patients. This was built in 1982. It still works because of community participation. And they were very much interested, and we invited the community health workers, community health volunteers of the area, so that they could explain what they are doing to our medical students. We had also the TB and leprosy coordinator of the county, and he stood up and he showed a person, and he told, what do this person have? What does this patient have? Nobody was seeing anything. What do you see? Nothing. But then this person showed his hands to the students and turns his hands around, and what do you see? That was a patient with leprosy. You see? Damage of nerves, he doesn't feel anymore, he gets wounds in his feet, in his hands. So I asked the students, who wants to investigate leprosy in cooperation with local community health volunteers and also health staff? Might be we have a new epidemic, of might be we find something. So these are the students, we discussed it together. And what was the rationale behind the idea? Maybe there was a large increase in population resulting in more leprosy. People settled more because this area is a semi-nomadic area, and there's more and more villages. People live close to each other. There's a poverty-stricken area, so that are at least risk factors for leprosy. So we ended up in a case study. These students wrote very quickly a case study, and because the community health volunteers, we have at least 20 people with leprosy in our village and the surrounding. So in this semi-nomadic nomadic area, we believe that there might be a higher leprosy prevalence than actually registered. And we ask ourselves the question, are leprosy-trained community health volunteers able to detect new leprosy cases in West Pokot County? Because our students found 8 true leprosy cases among 20 suspected ones in this village in Serewa. So what we did, that was, because I am the advisor of the government there, we trained community health workers at random, a group of 10, and we gave them the possibility to search during 2 months in their own villages where they are responsible. So they found 150 subjects suspected with leprosy, according to the community health volunteers. And what we did, we went with 2 medical students, you see, of Erasmus, who wanted to write their master screening of master thesis. And we got a team of people in Kenya, a laboratory technician. This is the chairman of all community health volunteers in Kenya. He reads 2,000 people. There's a medical student from Nairobi, and this is the person responsible TB and leprosy control in the county. So we went and looked to all these 150 people. We did research, their height and weight and things like that, under very difficult positions. This is our laboratory situation with the 2 medical students. We had support of Leiden, Alderaan University, Erasmus, so we could do the most modern research. But let me show you the social and economic conditions of, for example, women in this area, to give you an idea of poverty in the region. That is what women have to do. They milk plants to get oil for your nice creams and things like that. How is this called? I don't.
Agave.
Huh?
Agave.
Yeah. So they have to cut to break stones for their money. They have to climb trees to get some food. Let me show you 3 patients. This boy is one of the 150 suspected leprosy cases according to the community health volunteers. And what do you see? A white spot in his eye, above his eye. But if you look more carefully, you see these spots in the eye, both sides. You see? Who knows what it is? Peter, don't say. That is poverty-stricken disease. That is vitamin A deficiency. It is beetle spot, you see? It was treated by the Egyptians already with liver because they knew already. Patient 2, a young lady of 25 around. That is her food. Tropical ulcer. She's mother of children. She lives in the most unbelievable poverty area. Patient 3. This lady is more than 70 years old and she suffers from a disease for 30 years already when we meet her and nobody knows what it is. Never anyone made the diagnosis. Did are her arms. Did the legs, and you see very characteristic skin disease. Did are the feet. So that was a leprosy case, after 30 years diagnosed. So what you also did, contact tracing of this lady, we went to where she lives. We had to struggle. We went with a Land Rover and then we had to walk half an hour through the bushes to her house. There we go. Her hut, there she lies in front of her villa. You see, that is the area you have to think about. Primary health care under this situations. What do you do to bring these people health? So we went there and did contact tracing, and she was very angry, the lady. She said, what are you coming again? Source and contract tracing? No, I want my medicine. In the meantime, she has medicine. But this is her daughter. Does she has leprosy? This is her son. So the new leprosy patient, let me show you what poverty is. This is poverty. This is her house where she lies. This is her kitchen. These are the kitchen utensils. These are her clothes. You see, this is poverty. This is how she cooks. This is her kitchen. This is the dried meat she survives on. So results and conclusions of the study. We found under the 150 people traced by community health workers, patients with these diseases. You see a very clear leprosy, most of them. And 20 of the 109 of the 150 we could trace were diagnosed with active leprosy, resulting in a prevalence of 8.1 per 10,000 inhabitants, thanks to the work of community health volunteers. So shortly trained community health are able to detect leprosy cases with grade 1 to 2, and this survey in Westbrook known and unknown cases of leprosy were found, and all required multi-drug therapy. So now again, you become the director. What should you do? Don't do like this a medical student in Tanzania. We traveled to Tanzania and met a group of medical students in Tanzania, and we climbed together in a bus with medical students from Erasmus. And the driver was starting to drive very, very quickly and very dangerous. And I told the driver, please drive only 80 kilometers an hour. And then the Kenyan student started laughing very seriously to me. He said, what are you doing? Leave this driver alone. But the driver continued to drive 100, 120 per hour. And then I said to the medical students responsible for the bus, please let us go out because we don't want to die in Tanzania. And then the chairman of the Tanzanian medical group students said, who think you are? It is Mungu who decides where you're going to die, not you. Mungu, God. If you believe not in change, nothing will happen. So happily, when you go to Erasmus Medical Center, you see that the primary, all types of healthcare are there. Primary prevention, population health, screening, medical interventions. So are you in the proper surrounding to understand about primary health care. Thank you very much for your attention.
Okay, thank you very much, Paul.
Yeah.
There's one question, I have to look it up. There's one question in the chat that's about your global burden of disease more in the beginning of your presentation. That says, does it mean that in an ideal health system, all deaths are from non-communicable diseases?
I don't, can you repeat the question, please? Is there
in an ideal health system, would people only die from non-communicable diseases?
A very nice, a very interesting question, of course, but COVID-19 proves that infectious disease will develop all the time, depending on our way of living. In the past, we had all types of infectious diseases, and we could fight most of them through vaccination and improving the sanitation situation. But if you believe that we have something like evolution also of germs and viruses, then these will always come back. So there is a need for good sanitation and quick diagnosis and vaccination programs, and then you can fight infectious diseases. And what you see now, for example, in the Netherlands, we hardly die of infectious diseases. We have still 2,000, 3,000, 4,000 people dying of the 150 of infectious diseases. But the patterns in countries where we don't have proper sanitation, no good drinking water, no hygiene, no sanitation, no proper vaccination programs, there you will still see that infectious diseases remain important. And even if you have leaders like Trump and Bolsonaro and who think they can lead countries without respect for primary health care and public health, you will see that people will die of it. So it very much depends on the situation, but if you do a lot of prevention, you can fight them easily.
Okay. So are there any other questions so far? Because otherwise I think before we go to Peter, we can have a 5-minute break. Is that okay, Peter, with you? Just sanitary stop, coffee and whatever. So let's say it's now 11:57, so 3 to 12, that we restart at 12:05. Is that okay with everyone? Peter, with you as well? Okay. So be back in 8 minutes then.
Ben je er klaar voor, Pieter?
Totaal. Ik wacht op het verlossende woord van Jan.
Jan de Verlosser.
Ja. Hoor je mij?
Ja, we horen je.
De dia-presentatie zichtbaar nu?
Ja.
De presentatie is zichtbaar. Zouden jullie mij jullie presentaties ook even nog kunnen sturen na afloop? Dan kan ik die online zetten. Dan,
Ja. Je krijgt een link naar Dropbox, dan kun je hem eraf.
Ja, is prima. Is prima.
Maar jij wacht nog tot al die schermpjes weer oplichten?
Ja, we hadden gezegd 5 over, dus dat is over 1 minuut. Dus,
Oh, zo. Ja, ik dacht 3 over. Maar, okay.
Jan, ik moet de Kenia-groep begeleiden. Ik heb
Ja.
nog niet hun namen en zo.
Oké, die zal ik je nog even sturen. Ja.
En wie initieert dat overleg?
Het staat in principe wel ingeroosterd. Maar zoals je dat alle jaren altijd gedaan hebt, en dat heb ik ook tegen de studenten gezegd, kan je dat ook prima zelf met ze organiseren op momenten dat het een ieder goed uitkomt. Dus,
Ja, want ik heb, zover als ik weet, niet het onderwijsrooster van jou.
dacht dat ik die gestuurd had, maar anders dan stuur ik je die strakjes nog even, het complete overzicht. Oké, Pieter?
Oké, thank you, Jan.
Je bent er ready voor. Je introduceert jezelf, neem ik aan? Ja? Oké. Go ahead.
I'm Pieter van Hombergh, and I'm a long-time general practitioner. And if you live long enough as a GP or as a doctor, you finally become a consultant. So that's what I am today. And I have had a permanent interest as a family practitioner and previous tropical doctor in international health and global medicine. And I did many trips and activities so that all that experience is PowerPoint more or less. So I hope you're not all too tired if you at the end of this PowerPoint. We're going to see. But what I'm trying to sell to you is that family medicine is actually a very necessary discipline. The principles of family medicine are very necessary to improve healthcare around the world and especially in Africa. Although you would not think of a general practitioner or a family practitioner to be somebody who is very useful in Africa, measuring a blood pressure or something. But you have to change your idea completely about the way family medicine is operating in Africa. And I think the family medicine principles and introduction in low resource countries is a key step for establishing universal health coverage. And universal health coverage, Paul already has said something about it, so I can be a bit short about that. I'll give you shortly some information on that. Because this universal health coverage is coming from background values we have as a humanitarian society. We think that healthcare is a moral obligation and that good healthcare is an indication of good governance. You see, every country, you see the United States, they have worse healthcare than Cuba. And, but at the moment, everybody says that due to the bad governance there, and I think it's true, healthcare should be offered within the context of people and the environment. And Paul has stressed that very much, so I don't spend too much time on that. But the context can be very variable. You see, if you are giving healthcare service to people in the bush, as Paul explained, or you give to upper middle class African people healthcare, or to people more or less in between, like this Kisi, Kisi, no, it's not a Kisi, it's a Kuyu tribesman. who's sitting on a squat. All these people need adequate health care. And how are we all going to organize that? And my point is that you need generalists for that. You see, if you have only specialists, all 90% of the complaints will be treated inadequately. And actually, that I had this discussion a lot with Paul about why I believe less in systems and in structures than in people. If you have a dispensary, doesn't mean that you have good healthcare. So you can build a dispensary, but you need a good team that's motivated to make healthcare work. And so what I think is that the primary healthcare organization in low-income countries was too much based on building structures and not on getting the right mentality and the right people in that system. The performance of primary healthcare providers is really poor. They did research in India, Tanzania, Paraguay, and Indonesia with the same instrument, and they found that time on average spent with the patient was only a paltry 3.6 minutes, and completing the recommended history and physical examination was only done in 33% of the people. And the diagnosis was provided only in 36% of the cases. And of these 36%, the providers had the correct diagnosis only in 12% of the cases. And harmful or unnecessary treatments was 42% versus only 30% that were correct. And in China, another research, clinicians completed only 18% of the items of a recommended checklist on a certain complaint. And they provided the correct diagnosis in just 26% of the patients, and dispensed harmful medication in 70% of the
Nee, nu ben ik voor kloosterman. Want
What?
hier
That was the question?
laten. Dat is heel awkward.
Is that a problem?
Nee, om een minor.
But Peter,
Yeah.
how do you define primary health care providers? What are these? Primary health care is indeed structure and systems, but it has also to do with agriculture and sanitation.
Sure.
So are you speaking about doctors in primary health care? Who are these people?
No, this is also nurses, clinical officers, medical assistants, and all these people. But even so, in rural areas, if there's no doctors, you usually have clinical assistants or nurses or maybe community health workers. But they have not been properly trained, or they don't have the means, etc., to give proper health care. You see, and the proper health care, the definition is not so much telling as that the healthcare you want your mother to have if she lives in a low-income country. So I like everybody to imagine that they sit with their mother, and your mother has 3 days of dyspnea, cough, and she's tired after climbing staircases. And she has been in that health center before. She had some glucose in the urine, and she lost 7 kilograms of weight. And then that urine became okay again. And her children rarely visit her. She lost her husband a year ago, and now she's very tired and needs urgent help. And now I want you to think, what care does your mother deserve? What does this mother want as she stands in front of that health center? Try to think, because that's the sort of ideal health care you want to have. Does anybody have a suggestion? I like 1 or 2 answers, just to keep you attentive to the lecture. Who can chat or say something?
I would say that I want my mother to get the best help and to get good attention by the doctors so that she gets better.
But what is the best help? What sort of help? mention one or two items? Marloes.
I'm not a medicine student, I don't know.
Okay. Somebody else?
Yeah, there's a remark by Leonard Heuvelman. He says a clear diagnosis and specific treatment.
A clear diagnosis and specific. So you need the equipment to make a clear diagnosis, and you need the knowledge to make a clear diagnosis. Okay, well, for time, to save time, I go quickly to the sort of solution. So what you want for your mother is that she gets a proper access, that there's somebody who says, oh, Mrs. So-and-so, you have an appointment and we're going to help you quickly because I see that your condition is serious. And you need comprehensive service. That means comprehensive. Comprehensive means wide diagnostics. An EKG you would like for this mother because she may be having heart failure, or she may be having asthma. You would like to have a spirometer, or you would like to do saturation. You would like to have lab services and to give adequate treatment. And you like this mother to come to that health center not fearing that she will have to pay a huge bill or that she's unnecessarily referred in this condition. And you like her to be not at the end of a waiting list of 500 patients. You see, you like her to, because she's urgent, to become before somebody else with the flu. And you also like the doctor or the nurse or the health, the clinical officer to know her history. There should be a computer where there is a history of her glucose or her diabetes, which has recovered, etc. And you like a respectful approach, that they explore her view, what she wants. And you like that they involve the whole team in the treatment of your mother. And also that the family of the mother is also integrated in the care, so that there's what they call in Dutch mantelzorg. So that's the sort of care you want for your mother. So how can you organize that? Now, well, that's what general practice or family practice is about, that you have family-centered, continuous, comprehensive care, equitable, team-based, collaborative, coordinated, integrated, accessible, and high value. And that's what you just saw for your mother. So all these words didn't mean anything, but if you have your mother in your mind, you think all these things are very valuable. That's what you want for your mother. Is that clear? And then that's a huge task. And it's a huge task even in Western countries. Many countries have not been able to realize that. And so how are we going to organize that? You see, you can't do that alone. You need a team because you need to do all these tasks Paul already has mentioned: the prevention, the case finding, the emergency care, the contact tracing, who are under your responsibility. But you have to take care of your practice population too. So these things are conflicting. You need, in Holland, it's easy because we have the GGD who's taking care of the COVID. But if you, as a GP, had to do all these things, that would be impossible. So you need a team. And what you see already also in Holland is that the one and only GP in the 60s has now a team of maybe even 20 or 30 people to do exactly the same task, or even more, to give the health care to your mother so that she doesn't have to go to the hospital, adequately treated in what they call the primary care, in the first line. But in Africa, that's different. In Africa, people present with a fracture, or they present with big community health problems like leprosy or TB or whatever. So you have not the power and the professionals to give so much personal care as you would like to do, you see. So what Steve Reed explained by this graph is that you have actually to broaden the the approach of the family medicine in the rural areas, so that he can do a cesarean section, or that he can repair a fracture, and that he also can command a team of community health workers to help him solve the problem of pneumonia in children or something like that. So it's a different context and you need a different approach. But it can be done. And that's one of the things I hope to be have explained to you after this lecture, that it can be done and that it is just a matter of believing of commitment of the government to family medicine principles, you see. Because if you look at the top 10 diseases, we can see the top 10 in a dispensary. This was from a dispensary in Eldoret. Then you see malaria, pneumonia, diarrhea, upper respiratory tract infection, typhoid, urinary tract infection, TB, AIDS, skin conditions, and eye infections. They all can be treated very well by a very experienced, by a very well-trained doctor of clinical officers in primary care. And they should be treated there. So the patient deserves it. It's a moral obligation. It's one of the Sustainable Development Goals of the 2030 that everybody is treated properly in the place where he comes, in his health center. But even in countries around us, they're amazed by how well it is organized in Holland. For example, I had a visiting German professor, and to my surprise, he was very much impressed by our handboek verrichtingen in the huisartspraktijk, where you could every treatment, every removal of a lump, or every nail extraction or whatever was extensively described with pictures, so that every GP could look up what he could do in his general practice and could save people to be sent to hospitals. It makes the task of the GP really broad. And that's why GPs are always in problem with the government and the insurance companies, that they are not actually signing to treat everything, you see. So that's the joke on the right-hand side. But if it can be done by the GP, you see, GP is actually too person-centered. You see, the GP is not. You would like actually to have a family home with maybe a GP, but a family home that is a medical home that is family-oriented, that is clinically effective, and where all the professionals think according to these family medicine principles that we have just discussed. And I'm going to give some examples from how that was organized in Kenya. But first, back to the science, because there's actually proof, scientific proof, that this approach works. There's this fantastic lady, Paul has actually met her. I met her myself only once, but Paul was in Johns Hopkins in the United States, where she was actually teaching. And she did a research in the United States where she calculated the number of family practitioners in every state. There are 50 states. And the more family practitioners there were per 100,000 people in a state, the better the life expectancy, the better the neonatal mortality, the better the stroke mortality, and everything. That was corrected for the Gini coefficient. That's a coefficient that corrects for income inequality. And so that was a very interesting study, and it would really help governments to be convinced that they had to have a policy of investing in primary care. But this primary care guy has to do a lot. He has to be a care provider, a consultant, a capacity builder, a supervisor, a manager, and a community leader, and a researcher. It's a huge task. So that means that if we train these people, we have to train a lot of them, and we have to train them in all these capacities to be adequate at his position. And you have to believe in that, because that training is expensive. If you don't do that training, then you have a problem. So family medicine is concerned about clinical effectiveness for all. We are constantly concerned, can we do the right things? Can we show that we did the right things? And let's hope that we are rewarded for doing the right things. That's the constant concern of family medicine. And now are we going to look at a number of countries with these glasses. I put my glasses on. You see, these are glasses of a GP who looks at countries and thinks, oh, what is not family medicine oriented in this country? And do they have a culture of evidence-based medicine? So here you see, for example, a few examples of where the political orientation is lacking to give proper family medicine culture. For even in Germany, I was surprised to see in Germany that there's a huge shortage of family practitioners in rural areas. So I had to come to Berlin to explain to to a committee there why we were so successful in getting GPs in Holland. And I found out that in Germany, the government says, well, the training of GPs has to be paid by the insurance companies. And the insurance companies say, oh, the training of GPs has to be done by the government. And so nobody's paying them. So who likes to be a family practitioner training for 3 or 5 years, as in Germany, where they don't pay a penny for the training? And so they have a big problem in getting enough family practitioners. It has to be made attractive. And that means that politics is important because the politicians have to believe in it. And in Holland, we have a fund for that, where you have billions of euros paid to train specialists, but also specialist GPs, which makes the profession a lot more attractive. So what happens in other countries is also where you have politicians who only believe in public health and primary care. What you see, to your surprise, is very nice buildings. You see nice buildings there with no patients, because these patients go to private doctors. So what happens is that actually these people pay twice. They pay for taxes for their inefficient public health primary care system, and they pay for the private doctor because they want good care. And that's completely ridiculous. So how can we possibly solve that? Because this is everywhere. Eh? All Arab countries, all in India, many African countries, you have this dual system of insufficient public health systems and lots of private doctors where only the wealthy and the good-to-do can come. In China, it's a different situation because there you have no private doctors, but they have no GPs because they invested in village health workers, which was a bit of a problem, you see. I think it was a nice concept, the bare feet doctors, but they didn't train any higher personnel who could be leaders, who could organize this. And now they are changing the policy and they want to have 1 family practitioner per 2,000 families by 2030. And if Chinese people say that, they do that. It means training 300,000 family practitioners in the next 10 years. I don't think they're going to manage, but anyway, they have that intention. Here you see the head of Paul looking at the screen because we were there together in China. And this was a sort of an example health center where they had all sorts of material to show diseases for smoking and heart, etc., etc. And this is what they want to roll out all over China. Why did they do that? Because they looked at Hong Kong, and Hong Kong has the British system, and Hong Kong has a very adequate health system. They have a national health service. So actually China is copying what's happening in Hong Kong. But what is the problem in China? If you look at China, they have maybe political commitment now, but they have a very strange old non-evidence-based healthcare system. Here you see, for example, an infusion hall where people are sitting with drips. Well, what's going on there? You see, I was amazed. There were rooms where there were 30 people sitting with drips, and these people come in with complaints like dizziness and weakness and all these psychological complaints, and they're not addressed accordingly. You see, they're just they put a drip in them and then they send them home again. So this is a very inadequate system, costing a hell of a lot of money. But there was a lot of healthcare completely not evidence-based in China. This patient with moxa, he was having moxa therapy and some electric therapy on his head to treat him for his hemiplegia, for his stroke, which is completely inadequate. And he also got acupuncture. And they even have high frequency therapy. You see this huge apparatus there. And all this inadequate healthcare has to disappear. And it's going to be difficult if you know that the World Health Organization has had the problem that they had to accept that China, so Trump had a point that China was pressing so much to get alternative medicine of China, acupuncture and that sort of stuff. Official World Health Organization list of adequate therapies. So there was a big row over that. So there's a lot of political struggle even around evidence-based medicine. So we still put those glasses up there. I put them on again to tell you that we are looking with the glasses of family practitioners. And now we also want transparency and reflection. What does that mean? Now, if you look at countries and the way how transparent they are in their healthcare system, I was amazed to see in Rwanda that after the genocide, there was a whole new mission to become much more open society, much more accountable to people. And all of a sudden I saw things like, here what you see is a roadmap for in the beginning of a hospital where you had to be. I've never seen such a thing in Kenya or in Tanzania or in Uganda, but they had it there. But they also started to do things like that the laboratory people had their phone number on the door of the laboratory and they had so that everybody could see who are the laboratory people, and if they're not there, how can we reach them, you see? People in Africa are sick and tired of absenteeism, which is a nice word. We don't even know that in Holland. Absenteeism, but it is something like not being there. When you're there, it should be there. And that happens a lot. That's a disease in Africa. And they also had a complaint box now. And this is very nice. Here you can see the vision and mission that the health in Kenya, a family practitioner trained in Eldoret, became head of a hospital, and he immediately put a vision and a mission at the entrance of the hospital. And there should also be a continuous concern, and I hope that family practice can bring that amongst healthcare providers, doing the right things. Because the first thing first, if you remember the pie that Paul was showing, that about leading number death cause in the third world is not malaria, not AIDS, not TB. It's just stupid pneumonias in children of 4 or 5 years. And now don't think of your grandmother, but think of your mother who's having a child of 4 or 5 years, who's dying in her hands. That's falling, that's still happening, which is very unnecessary. And that's because they don't recognize enough the symptoms of early pneumonia threats, like tachypnea, etc. So here you see a community health worker with beads counting the breath of that child. And in the future, I hope that can be done with telephone apps, that the iPhone or the whatever phone, the Android phone, can put on the chest of the child and register the breathing and also the heart rate, so that children at risk can be much earlier detected and get antibiotics. And in Ethiopia, they proved how much successful it is to involve community health workers. You can involve them for leprosy, as Paul showed, but pneumonia is a much bigger problem. And if you could make all community health workers very attentive and aware and as accessible for patients with such a child who is at risk, who needs constant monitoring to be sent in the hospital in time, that would be an enormous improvement. And they did that in Ethiopia. They trained thousands and thousands of these community health workers. And that's why this Gabriel Jesus, the guy now from Ethiopia who is in the World Health Organization, he was the Minister of Health who believed in that. And he was the Minister of Health who believed in family medicine principles. So isn't that an
Sir, you're muted. You are muted. Je bent, zeg maar, je microfoon staat weer uit. Hij is niet eens uitgevallen.
Pieter, je ding staat uit.
mute now? Okay.
Yes. Dankjewel.
Is that already for a long time? Do I have to go back to this?
Nee, ja, alleen deze dia.
Nee.
De laatste dia niet. Dus vanaf hier, deze dia was het nog wel goed.
Okay. Well, now, doing the right things, it took me a long time. You see, I started as an innocent tropical doctor in Kenya. And one of the first things I thought is, how can I get an idea of what healthcare is provided by this hospital? And maybe I instead of operating, I go a morning with the mobile clinic to see what they do in the bush. So I went to the bush, 2 hours drive, and then I looked and I saw that the container only contained some smallpox. At that time, it was already extinct also in Kenya. And there was a few bottles, as you can see, with gentian violet and iodine and some gauzes, and that was it. And I said, who is responsible for filling the box of the mobile clinic? Oh, I don't know. I just came on duty, that guy said. And actually, that's not the guy to be angry at. You see, he is just a student who came with me. So it's not easy to see if you're sitting there, how can we handle 90% of these complaints? So how do you do that? What would you do if you were sitting there? Does anybody have the guts to tell me what he would do?
I guess doing nothing is not an option then.
What?
Doing nothing is not an option.
Doing nothing is not an option. Yeah, but what can you do? Can you be angry at that the container was not filled, or are you going to shout at the matron of the hospital who is responsible for the mobile clinic, or what are you going to do? It's very difficult to see.
Anyone, just shout.
Okay, did you ever hear of a quick and dirty survey on what in a community? Did anybody hear about that? You see, what you can do is that there's a whole technique for that. I didn't do it here. But actually what you like to know is if you see 100 patients in the morning, what diseases do they have? And what do I need to treat 90% of these diseases? And then, if you know that, you can see that there's, for example, here, they presented with pneumonia, with malaria, with scabies, with abscesses, boils and stuff. They presented with fungus in the hair and that sort of things. So what you need in the box is malaria tablets. For diarrhea, you need Flagyl or whatever, another oral rehydration fluid. For the scabies, you need ointment. And all these things should be in that box. But you first have to do an assessment on the top 10 again. And if you have that assessment done, you go to the matron, and I said, I've done some homework. and actually seeing those diseases in the bush, I need this and that and that. Can that be done? Maybe you discuss it in the management team or wherever, so that next time it is implemented. And that's you have to think in advance of this, and that's what you call management. It's not becoming angry. No, you have to think, step back, think what is necessary to be done here, and do all these things. And I tell you, I didn't do that myself the first time. I became angry, and I've learned over time that that wasn't the wise approach. So that's what you learn if you learn a little bit about management. Management has a bit of a, nobody likes managers, and managers are awful, and that's true. But some of the management techniques are very useful, especially if you go to low-income countries. So doing the right things, it's very difficult. So imagine this patient coming to the hospital. And I thought I was a very good doctor, because why did I think I was a very good doctor? Well, I saw this patient, I saw his abdomen concave, that he had and he didn't eat well, and he was vomiting and losing weight. So I thought probably he has some sort of obstruction. Let me make an X-ray. So I made an X-ray, and I saw this patient having esophagus carcinoma. But I was still a stupid doctor. Why was I a stupid doctor? Because I wasn't a family practitioner at that time. I was a very specialist, hospital-oriented chief doctor who didn't ask the patient, why does this patient consult me at this moment in this hospital with this complaint? What would really help this guy? Because he can't be helped. This is inoperable, and he has to go home. So I sent the guy home. But what would be good help? Why was I a stupid doctor? Who does tell me that? Who wants to tell me I was a bad doctor? I'd like to hear that from you.
Maybe.
Yeah.
Maybe you should have asked why exactly he came to you and what he expected from you.
Exactly. And what do you think that he expected from me?
Well, maybe just I don't know, to be diagnosed. I don't know.
I diagnosed him, and I help you a little bit. He has been to 7 hospitals before, and 7 hospitals diagnosed him, and 7 hospitals told him he couldn't be treated, and then he was sent home. So he spent already quite a fortune on all the X-rays in all these hospitals. Also, he was a burden to the healthcare system because he was never helped properly. So what does this guy need? What does he get in Holland?
Maybe he has pain and wants painkillers against the pain.
Sure, that's very good. How do you call that if you give painkilling?
Sorry?
How do you call that if you give painkilling?
A sedative? I don't know.
Palliation.
Oh, palliation.
This guy needs palliative care. He doesn't need a big doctor. He needs somebody who understands his problems, looks at his view, knows that why does he consult me at this moment? Well, because he's desperate, and he has been to so many hospitals and nobody helped him. So then you can give palliative care. He's maybe fearing to die, or he's maybe having pains and he wants to die properly. So you can tell him, you have to prepare, you have to inform your family, and they have to make a sort of an end of life program. So that's what he needs. So, I don't know if you still follow me, but we're still looking at countries, why family medicine principles, if they're not taken seriously, why it's not giving good care. And this is a nice example. I don't have to spend much on that because Paul already has addressed that. But you need to have politicians, doctors, healthcare workers who are proud of being a general practitioner or who are proud to be a generalist. They have to believe in this universal access. And here you see all these people with the yellow shirts. They're all community health workers, and they show the results of how they help families to build their sanitation, to build a pit latrine, to build garbage disposal, to keep things clean and nice, and to have a surveillance system in that community so that somebody who's coughing for 4 weeks would be sent to the hospital to be diagnosed for TB or something like that. So it's very interesting to see how proud these community health workers were, and they had some prestige, also some status by this T-shirt in their community. And I myself, 2 years ago, I visited Kenya to coach 2 family medicine trainees from the Kenyatta University. And that was so interesting because they had to do in a rural area a quality improvement project. So they went to the communities of the dispensaries and the health centers and asked what the problems were. They spoke to the community health workers. And what we found out that one of the biggest problems was that all the people came to the dispensaries and that 70% of them were just common colds and they all got antibiotics. So what was the problem is that the mothers thought that they had to go to the hospital because they got antibiotics if the child had a running nose. Well, you know, all children have running noses. If you go to crashes in Holland, the baby crashes, and you see only running noses. So imagine that all these running noses come to the health clinics and get treatment, antibiotics, just because the antibiotics were given for free by the government and the World Health Organization. So there was a total discrepancy, and it's all over Africa that you have, and also in the Arab world, all low-income countries, and in India and Pakistan even worse. Everybody gets antibiotics for nothing, and that's so we have tried to address that from the family medicine principles by practicing with the community nurses and the clinical officers. From if you find out about what the mothers expect, you see, you ask the mother, what do you expect? This child has a common nose. Do you take yourself antibiotics if you have a running nose? Oh no, we don't take that. So if you have this sort of interventions, you could probably change that. You see, we did that, and unfortunately, the publication about the reduction was very modest. Probably you need a much bigger intervention, but it was a serious problem, and it was very nice to do that with these 2 family practitioner students. And it also made clear that you need, even at the rural level, some leadership in family medicine principles. Otherwise, clinical officers or nurses are doing just, you see, easy tick off of antibiotics for every patient and send them to the pharmacy, sort of thing, and that's just bad. Remember from the first slide about this survey in the world about primary care, how many patients were misdiagnosed and mistreated. Another show about how family practitioners and family medicine principles and leadership can be successful is that I was actually amazed. I had to do a consultancy for the World Health Organization in the West Bank in Palestine. An awful guy who was a dermatologist, who was the head of the primary care in the West Bank. And then we had to go to Gaza because that was part of the mission. And I didn't expect anything of Gaza. I thought it was just poverty and nothing. But the amazing thing is that I found there this guy with a star around his head who was trained as a family practitioner in Egypt. And he was starting to train himself, all sorts of family practitioner ladies, doctors who he trained himself, and they trained each other with PowerPoints they picked from the internet. And here you see this lady, the other one with the star, teaching about breaking bad news, etc. And it was amazing. And they all, Gaza isn't that big, They all were head of a primary healthcare center in Gaza. And I was amazed. It was much better organized. And the only thing that probably healthcare is worse there is that they're so poor, and that Israel is really making it terribly difficult for them. But this was, for me, it was an amazing example of what leadership in family practice could do. So how far are we now? What did we do so far? No, not much. It's very slowly progressing. But in Kenya, where we started in 2013, together with many other people that were all with, but in Eldoret, the family practice training started. And it has now expanded to 5 universities, and 100 FPs have graduated, and 70 registrars are in training. And the Ministry of Health likes these people. They're fantastic, because you can put them in a hospital, and then the surgeon or the gynecologist, he can go on holiday. That was not exactly what we meant when we started the training, but that was but at least they acknowledged that these were very useful people. It's better to have a very well-trained generalist than a gynecologist or a pediatrician in a hospital. And what the nice thing was, is that none of these 100 FPs has left the country. None of them left. And that's a big problem with other doctors in Ethiopia and Uganda. All these doctors go to Australia and Canada. But none of these 100 FPs left the country. That's very special. And they nearly all became either medical superintendent or head of a health center, or etc. So it's too early to say we're trying to do such a study. And a study like that was done in South Africa. If it makes a difference, you see, because that's what you want to show. Because then people or governments would like to invest in family medicine training. If you could show that this makes a huge difference, you see. We could show that there was less corruption in family practice led. In Rwanda, that minister wasn't convinced, and she stopped the training, and she invested all her money in specialist training. We're still very angry about that. But in Malawi, it's getting off successful, and also in Uganda, Ethiopia, Sudan, Ghana, and Nigeria, family medicine training is becoming very prominent and active, and Wonka Africa is thriving. So I think there's a big future for family practice, but it still takes, I think, 20 years before you can see a considerable effect, but that's what I hope. Here you are the 5 universities, and this is Malawi, where you had the Dean of Public Health and Family Medicine together, because I think they should be under one umbrella, as Paul has showed in his dias and his slides. And here you see the undergraduate program. And to finish off, I think I can be proud to show you some research I did myself with the practice visit instrument in the Netherlands, where they did a patient questionnaire. And as you know, from 2007 onwards, there has been a huge investment in primary care in Holland. The training was paid, we got a practice nurse, we got health centers, we got a lot of support from the government in improving healthcare. And what you could see from the questionnaires, that there is a linear improvement of the doctor of 82% to 87%, and from 64 to 72 of the health centers, in satisfaction. And of course, that's no proof, but it's amazing, especially because to improve on a health questionnaire, if you go from 82% to 87%, it's only 5%, but most people fill in the questionnaire very positively. So the whole questionnaire is already skewed to the right, as they call it. So this was a very, very interesting trend which we published. The only thing is that you can also say, oh, that's because we changed to a market-oriented system. Probably that has also something to do with it. But I think the GP was remunerated, that got more money. Every patient was insured. From that time on, we had universal health coverage. And We had also a system of partly capitation, partly fees, which I believe is very good. And the investments were made in chronic care, diabetic care, etc., etc. Also, the time of the GPs per patient rose, and he could spend more time per patient. So I think we can be proud. That's the Dutch Association Board, who's very proud of what they realized after 2007. But it's still a difficult message, you see. It's such a difficult message. If you look at the GP in the 1970s in Holland, he was very inadequate in diabetes care. He treated all sorts of cuffs with cuff mixtures and all sorts of nonsense. So in his time, he was very adequate. But with the evidence of now, he's really passé. But it's very difficult to see that for male politicians, that this modest girl who is taking the blood pressure here is actually gold, that she is fantastic, that she's the cornerstone in a healthcare system. So people have to be shown, we have to be very transparent about how successful we are as family medicine discipline. Here's a not so typical FP. As you can see, I've worked with the Maasai. And this is a slide about that there's this mass uproar of medical students in Kenya, where there were publications that primary health care is the best bet for universal health coverage. And there were demonstrations about that. I was very happy with that. Okay, we need this investment in family medicine principles to reach universal health coverage. Thank you very much. Here is how I got all this experience by being a tropical doctor, policy worker, and a GP. Thank you very much.
Okay, Pieter, thank you. Are there any questions? I think Chris has a question. Long question. Oh yeah, so his question is about patients going to a doctor with a running nose. That it is perhaps not only the doctors you should train, but also the public, that for every running nose they shouldn't come to the doctor to get antibiotics.
That's a very adequate remark. Actually, that's what we did. We trained the staff, and the staff itself already came with a suggestion to, when these 100 people with running noses are sitting in the waiting room, that they should every morning give lectures about the normal course of events in upper respiratory tract infections. And so they changed their policy to doing that.
And I know that there has been a big campaign in Belgium for a couple of years already about, because there's a difference in Dutch patients and Belgian patients going to a GP. Because if they have a fever in Belgium, they go to the GP to get antibiotics. And in Holland, they come for comfort and uitzieken, om het zo to say in Dutch. But because of antimicrobial resistance in Belgium, they had this mass public campaign for the public indeed to not go to your GP and demand antibiotics if you only had a flu-like illness. So,
did it work?
At least the prescriptions for antibiotics dropped.
Yeah.
Not sure if that already translated into less antimicrobial resistance, but.
Yeah, that's the big issue behind it. It's the antimicrobial resistance. But it helps to convince people that if you take antibiotics, that people are more tired after recovering from the infection who didn't get antibiotics. And these things help to convince people that it's a good idea. And also this concept of the microbiome, which is disturbed, convinces a lot of mothers to not take antibiotics for their children. So I hope finally and now with the possibility of testing if you have a bacterial infection, with the PCR, I think it's also going to help for reducing antibiotic prescription unnecessary. But in the third world, it's still nearly everybody gets it, and it's a drama.
No, true. Okay, any other questions? Remarks?
Yeah, I have a question.
Yeah, go ahead, Paul.
Peter, when I understand your lecture well, you're really into good quality curative care, starting with the family doctor. Curative care should start.
A generalist, not a family doctor, a generalist. It can be a community health worker, a nurse, a clinical officer, or a family doctor.
But in the Netherlands, how is the cooperation organized between the family doctors and other people working in the primary health care?
Well, that's a disaster. I think even in Holland, that's still a disaster. Maybe it's nice that Paul and I have been discussing that, and we sometimes came to the conclusion that it's like oil and water. It never mixes. You see, the public health people, in my opinion, have an approach that they have some distrust towards these family doctors who don't cooperate, who never have collaborate as a united workforce, and who can be a trouble. So, for example, with the vaccination against cervix cancer, the public health people decided to do that themselves and not use general practitioners to do that. And the problem was that you had all these yelling people in big halls being vaccinated by people they didn't know, where they had no personal connection to, etc. So the GP said, why don't you do that in general practice? You see, we do the flu vaccination, we will do pneumococci in the future. If you do that, you can see a girl every now and then and give the vaccination. And then there will be no yelling and no fear and nothing. But it didn't happen. So, but also in COVID, I think that it is actually a waste of health professionals not to involve the 10,000 GPs in Holland in the treatment of, in the approach to COVID, you see. I think if a GP tells a patient to stay in quarantine, it's much more, much stronger message than when somebody completely unknown on the telephone tells you you have to stay at home 14 days. People just don't do that. They all be like Grappa House. They say they do it and they don't. So I'm actually, that's one of the sad things that all my professional career, I've never been able to contribute a bit to getting public health and primary health and family medicine to be more integrated. And I think they should actually be part of the same system, like in the UK. That's a lot better in the National Health Service. Is that an answer, Paul? Or maybe you have something to say yourself about it?
Yeah, you are very honest. I want to stress that the national vaccination program in the Netherlands reaches 95% of coverage compared to flu coverage and so on. So I wonder what is better, big halls and public health people and GGD'en, or we should not fight, I think. What I propose is that we train doctors, family doctors, together with public health people, and that they should understand each other. And that is not happening. There is a big separation. We have a special school in the Netherlands for training public health doctors. That is somewhere in Utrecht. It was even going away from universities. So we should rethink about it, to my opinion, so that public health people and doctors, family doctors, family practitioners cooperate, like you say, is going on in England. When I go to England to my colleagues, I always see that they naturally cooperate with family practitioners. So that might be something, and I hope that in Africa, I'm very happy to see that in one of the universities in Kenya, we have a dean for family medicine and in combination with public health. And I think that is something what should happen in the future. There should not be a fight between principles of public health and primary health care and family practitioner. And that is what I showed in the umbrella in one of my slides. Okay,
I think those are very nice words. I have no comment to that anymore, Jan. I think it's 1 o'clock, so you probably have to finish now.
Yeah, so there was one question about why don't these two disciplines communicate well or mix well together, but I guess that's discussion.
I hope that's answered by Paul.
Yeah, exactly. Okay, so thank you very much. I will get the slides from you, hopefully, and then I can post them online. And that's it for today. So see you all again tomorrow.
I hope you have a fantastic time in the tropics and you love it there, and that you all become family practitioners in the future, but also first being a tropical doctor. Bye.
Okay, I hope this helps.
Okay.